Yeah, good morning to all of you. On the last day of the conference, thank you for assembling here for this one. The session is Double Trouble in Cataract Surgery. We are covering scenarios where there can be different kind of problems in the same situation or in single case. So you can have a multiple of problems. You can have a problem like glaucoma associated with cataract or something like that. So here we have three different scenarios. One is cataract surgery in the setting of glaucoma, and then some retina cases which are complicated with another issue, and then cornea related issue along with some other thing. So we have 7 speakers for today. Let us just straight away go into the talk. I request Dr. MALLIKARJUN HERALGI. He's talking about cataract surgery in pterygium. So how to deal with a scenario where we have 2 different scenarios like that. Dr. MALLIKARJUN.
Good morning all.
4 minutes.
I'll be talking on cataract surgery in pterygium. And it's a very simple condition, but is a very often very difficult to manage, because most of the patients in our day-to-day practice, many patients will come with pterygium in different type of pterygiums and with different socio-economical background and different expectations and all. So sometimes it will becomes difficult to decide how to go about it. So whenever I see a cataract patient with pterygium, I think of 3 options in the management: whether to do a cataract surgery only, or a sequential surgery, do a pterygium excision first and then go for a cataract surgery, or a combined surgery together. So these are the possible ways how you can manage. And I have made a very simple strategy which is working well for me, and I do only cataract surgery when the pterygium is very small and the astigmatism is less than 1.5, and atrophic pterygiums, and which are non-progressive, which we have not, if you have seen them, if they have come to you for a regular follow-up, and you have seen that it's not progressive, for them I do only cataract surgery. And some patients will not be bothered for cosmetically, because I have a place where I work, I get all sorts of patients, like poor patients, rich patients, and some patients will be, they'll have very high expectations also. So depending on, I decide. And also I make sure that I counsel them, they might require a pterygium surgery later. Even they have undergone only cataract, they might require a cataract later. And when I do sequential surgery, if the pterygium is more than 1.5 diameter of astigmatism, and a progressive pterygium, big pterygium, and of course pterygium which are nearing to the people, young patients, they have a tendency to progress the pterygium. For them, I do a sequential surgery. And double head pterygium. These patients also we see in many patients, they come from rural area, and many patients will have the double head pterygium. There I do a sequential surgery. And this is one case, very irregular cornea, if you see there. And although pterygium is not very near to the people, it is causing a lot of irregularity and more astigmatism, and a lot of higher order aberrations patient has. So such patients I prefer to do a sequential surgery. For doing a sequential surgery after pterygium excision, at least we have to wait for 3 months. And if you have done a larger pterygium excision, you have to wait for longer time, because it takes a very long time to stabilize. And if you have access to the topography, better to do a pre-operative and post-operative topography and assess the astigmatism part, and also you have option, you can assess the higher order aberration. The end point is stable astigmatism. Stable astigmatism, not the keratometric value. The patient what astigmatism he accepts. That is the endpoint that you have to take. Because these keratometric values might change later, but whatever the patient accepts, that you have to take in consideration and decide. And few tips for doing a cataract surgery after doing a pterygium excision. I do monofocal if the IOL astigmatism is less than 1 point diopter of astigmatism. If the astigmatism is more than 1.5 diopter of astigmatism, then I plan for a toric IOL. If you're planning for toric IOL, you have to wait for a long time. And the aberrations and astigmatism, as I said earlier, should be stable because patient will be unsatisfactory. Of course, for the reason of the pterygium excision scars and pterygium into dry eyes, and even if you have done a good pterygium, they will have a higher order aberrations. So better to avoid this premium IOLs like multifocals and trifocals in these patients because they will not be happy. When I do combined surgery, if the astigmatism is less than 1.5 diopter of astigmatism, small but progressive pterygium. If your patient has been coming to you for follow-up, if it is progressing, I plan for combined surgery. And patients with mature cataract, I'll go ahead with combined. And the patients are cosmetically bothered and they don't want 2 surgeries. Some patients, they tell, I don't want to undergo 2 patients, then such patients I do a combined surgery. What pterygium does is, it flattens the cornea in same axis. And after we remove the pterygium, it steepens there. So when you're doing combined surgery, you have to reduce the IOL power by 0.5 to 1 diopters. That would compensate for the change in the cornea. Some tips, all of you know, excision with conjunctival autograft is the surgery of choice for pterygium surgery. And you can either use fibrin glue or patient's own blood. And always you have to dissect at the level of the pterygium and don't dissect more deeply. That would cause more scarring and also healing takes longer time. So it's something you should aim for like this. So this is the graft and cornea looks clear here. It is often not possible in all cases, but as much as possible you have to try to make the cornea like this. And you have to explain to the patient that recurrence is possible. So if the recurrence is there, then again we'll have to go for surgery. And you have to remember, even if you have done a good excision and cornea looks clear, they will have a little bit higher order aberrations. So good counseling is very important in these patients. Thank you now for the discussion.
Thank you, Mallik. It was a wonderful presentation. I have one question for Dr. Sudhir. Sudhir is a senior consultant to cornea refractive surgery at Shankar Netralaya. He's an excellent surgeon. So what is your indication for combined procedure, combined phaco with the pterygium, and when you want to do it sequentially, and how long you will wait?
Yeah, I agree with Dr. Mallikarjun. I think he has summarized it very well. Because when you're looking at refractive outcomes in all the cataract surgeries, I think pterygium is only basically a cosmetic, and for refractive, I think we have to be very careful. If the astigmatism, we go much further, like even less than 1. If there is astigmatism, because we screen all the patient with keratometry, and if the keratometry shows astigmatism, absolutely we counsel the patient not to go ahead with the combined surgery, have a sequential. And I burned my fingers initial days when I did a toric IOL. The patient came from military and he wants XX vision. He had a pterygium surgery done elsewhere. It was 1.5 months. He didn't tell me, he told me it's 3 months. So then I had no choice to go ahead with the toric IOL. We were so happy with 6/6 vision at glass appointment, but he came back after 3 months with a residual astigmatism back. So it is very important that we have to wait minimum 3 to 4 months. Like what we do, the scar modulation occurs until at least 4 to 6 months. So, but if the cataract is very dense, then we have to go ahead and tell the patient and counsel. 3 months is a minimum thing for the scar modulation. Otherwise, you have summarized all the points well.
There is one new paper which has come up. The authors, they do anti-segment OCT to know the depth of this pterygium, and if it is deep, if it has penetrated the cornea beyond Bowman's, so there is a chance of wound modulation for a longer duration, which can go up to 6 months. So, like, I think if you have a tool like anti-segment OCT, it's better you do a OCT and see the depth of this pterygium, and then plan your surgery accordingly.
It's a very good point, but everybody won't have access.
Yes, sir.
Everybody won't have access to anti-segment
Yes, you
OCT.
have an access.
So even if you have a Scheimpflug camera,
Yeah.
Scheimpflug camera also can give a little bit information of the depth of the pterygium. Even Scheimpflug camera, the image also can give.
So another thing about astigmatism, surgically induced, since I'm in a government institute, we are carrying out research all the time to look for the reduction of surgically induced astigmatism, and we talk about on-axis incisions and all that. So is it possible in regressive pterygium to, to neutralize by your site of incision for the surgery? Site of corneal incision.
Corneal incision.
Yes.
So if you are doing a clear corneal incision, if you are doing less than 3 millimeter, you are quite clear.
So we still find 0.5 to 0.75 is still there. And now the latest candidate has been given as research, endothelial cell loss between SICS and FECO to put money where our mouth is. But I was just interested if you had studied the SI, the surgically induced, if there was any change post-operative.
No, you can go and you can go ahead with the dose. You are doing SICS. Go put a section at the steeper meridian.
Exactly.
So
yes.
that would reduce.
It
at
helps
least about,
in these patients
Yeah.
because we did a study on pterygium with the supratemporal area for harvesting the autograft. It gave good results, but long term there was some recurrence. So I just worried, but it was very nice.
So nowadays, what I am doing, I don't take the graft from the superior area. I take in the inferior area.
Astigmatism will also change.
So
You want
in
to
that,
preserve it for
preserve for
future,
the cataract surgery, and also if the patient, in case many glaucoma specialists are there, they would agree with me. In case patient needs further surgery of some blebs, then
filtering surgery, yeah. Doctor, you mean to say you want to put incision superiorly for all the cases? Because you end up having visceral astigmatism in pterygium.
Yes, sir.
You put
So,
superior incision
with
for
the
all the
rule
cases.
superior, with the rule superior. Sir, I'm head of glaucoma in the institution, so I like to save the site for future.
I know.
The little stingy about that.
Pterygium may grow subsequently, and the amount of
Recurrence.
astigmatism can vary. So, if you are correcting astigmatism due to pterygium by incision, subsequently over the time, it may change.
Because
No, so my other concern
it's been proved that your surgically induced astigmatism is just 0.1 diopter. Even the centroid studies have shown that it's just 0.1 diopters. By placing the incision on axis, it hardly corrects your astigmatism by 0.1 to 0.2 diopters. So for that, I don't think.
About SICS and
SICS,
plus I'm
you
talking
meant-
about the combined surgery. Even the pterygium post-operative, you say the steepening will take place. That will also take place over time. So
Over
again
time,
there
yeah.
will be.
Compensation. Yeah.